Hi everyone. As we know that from this semester onwards, we are offering some of the lectures as blended learning. So these lectures are only available as an online mode, and we have some associated activities with it. So just to give you some idea of what we are trying to achieve in these type of session is create as much as realistic environment in which you usually have face-to-face learning. Fortunately, we have a lot of resources available. We have technology that can um, merge things together nicely. So I think when in fact you are actually when you are watching this video and doing this activity, you'll find it much integrated as compared to myself, who is basically putting all these puzzles together. So, what we are going to do in this session is we are going to have this short presentation that I'm doing right now. In this short presentation, I'm going to show you some of the materials that you'll be referring back to while you are doing your studying, and all of that will be presented in one page under the module in Minerva, where you can just watch the video and then access all the material within that one single page as a links. So um, as I told you, three basic components. The first one I've already described you, that we are going to have some brief talk covering the concept that basically you are watching. But beside that, I will also identify some essential readings and perhaps watching of at least one video, if not more, about deep prescribing. I will also show you that where you can find information to apply the concept, and I'll go through with an example with you as well of applying deep prescribing in your practice. Now, the objective of this particular activity, the first activity of this talk, is to define deprescribing, is to understand when we should deprescribe, what are the indications for deprescribing, to understand some of the challenges or barriers we face while trying to deprescribe, and then what are some practical tips on implementing deprescribing and what resources are available to you. So, deprescribing in its simplest term is just discontinuation of drug. It is also a process of a trial withdrawal of inappropriate medication. The reason we say trial withdrawal of medications is sometimes we think that medicines are not necessary or they are inappropriate for a particular patient, but later on, when we stop that medicine, we may experience some symptoms are coming back, or the reason for starting that medicine may come much more strongly after trying to withdraw that medicine in a particular patient, and that's why it's also considered by one of the expert in the field, Reeves et al., which is basically Emily Reeves. She considered it as a trial and not just a one-way street. Um, Also, a much more comprehensive definition by Woodard is reviewing of the current medication, identifying those medicine that need to be stopped, and then just like prescribing regimen, prescribe a deprescribing regimen in conjunction with patient and offering ongoing support. And that also required review. So basically, the definition 2 and definition 3 is kind of an explanation of definition 2, which considered as a process, while this define how process should be. You all may have heard of medicine optimization. It's something that is highly supported by NHS, and it's basically quite an important aspect of medicine management. It's an approach that is patient-centered approach. We have four principles. The first principle is that we need to establish the value of patients, understand what they really are feeling, what really matters to them, then identify the best choices based on the most strong evidence, then trying to make sure that the medicine use is as safe as possible by making sure that we are adjusting the doses, we are making sure that we are monitoring patients so that we can avoid side effect or detect them early and manage them, and also make this medicine management or optimization principle as a routine practice. So try to inculcate into the culture, try to integrate the processes into what we usually follow so that these principles are operational and not just some you know slogans or um, mission statement without any action beside them. So excuse me, my take on deprescribing is very simple. We should not prescribe medicine when there is no definite need for medicine. So the deprescribing should start from prescribing. Uh, a very simple way of explaining it is that in theory, whenever we prescribe medicine, we should make sure that medicine is the best possible solution for an outcome that we are targeting. It, and the choice of the medicine, the choice of dose, the choice of the frequency of medicine should be the one that will offer the maximum effect or the most benefit out of it while minimizing its the harm, and it should be a well consented procedure. So in reality we inform patient most of the time that we are prescribing this, but at that time we should basically see if what that patient take is on medicine, on a medicine that we are starting, because increasingly we are seeing complex patients and these patients are already on a number of medicines. So maybe starting a new medicine is something that the patient hate to start with. So it's not a good idea to just prescribe the medicine and just ask patient to carry on with it no matter what. Um, Basic reason for deprescribing medicines can be summarized into few of the reasons. One is always the harm, and if you think about it, it's logical. So adverse drug reactions or adverse drug events or some sort of patient harm is one reason. So if medicine is causing more harm than it's providing benefit, or medicine is causing some sort of side effect that really impacting the quality of life of a patient, making patient miserable, patient is falling, patient is feeling dizzy all the time, patient is feeling completely lack of energy, or medicine is causing major organ damage, maybe medicine is causing liver damage or kidney damage. And if you think about it, very obvious examples. Long-term NSAID can cause gastric erosion. Long-term NSAID can cause kidney problems. Long-term NSAIDs can cause heart failure problem in high-risk patients. So there's one typical example of a medicine that is likely to cause a lot of adverse drug reactions. So we need to be very careful that whenever we are prescribing that medicine, there's some good reason for it. It must be short-term medicine. um, or the cost of medicine is way too high for a patient and is affecting the adherence, and that's why that patient is not likely to benefit as much from the medicine as that patient would benefit from a medicine if we use an alternative that may not be cost as much. Or if patients has, which is the most common reason, the last one, the too many medicine or polypharmacy, is the most common reason, it's most practical reason, because it's a powerful physical stimuli. So you see bag full of medicine. You see that patient has this fistful of medicines, and they're fed up of it. So that's another reason. And in most cases, when there are far too many medicines, patient is very likely to either do not take them irregularly, or take them not as per the prescription. And that begs the question that do we really need to pursue with all these medicine when we know that patients in reality are not taking all of these medicines. So at this point, why should we prescribe? I would like to introduce you to an excellent paper that I managed to find just for you guys. So there is this recent paper by Norton and Hayes. And the one thing that I really like about this patient, like this particular paper, is that it's written by people from nursing. So I'm pretty sure this is written by two nurses. Um, and also, another good thing about this paper is that it's really relevant to the practice. So it's talking about what does it mean to practice nurses. And another thing that I'm basically trying to sell this paper to you so that you guys are reading it instead of just putting aside. If you think about it, excuse me, I'm not feeling well because of some weird cold or viral infection that's happening these days. So that's why I'm having all these symptoms while I'm talking to you guys. So what I really like about this one is that is talk about, relevant thing that you guys can relate to, is talk about drug administration, some of the obvious prompt that nurses have in their routine practices. It's also talk about nurse prescribers, and it's also talk about competencies of nurse prescriber in older adults, and why they are not any specific one, and how you can basically look at it from your practice framework point of view. So I would encourage all of you to read it. The other thing I would like to tell you is that I was quite considerate about the reading burden. So I managed to find this paper which basically has 4 pages. I think is one, two, three, actually 3 pages. So if you think about it, it's 3 pages, and it will give you a very good introduction, better than my slides, about why we should be prescribed and why you should be prescribed as nurses, right? Now let's move when to deprescribe. So why to deprescribe and when to deprescribe are quite similar slides. The reason I have these two is so that I can go into specific examples. So medicine are causing more harm, as I told you about NSAIDs. So you can have like medicine are causing harm in terms of direct harm, in terms of side effects, in terms of drug interaction. And if you see, a lot of these are within your competencies of prescribing anyway. So you can relate it to, screening for drug interaction, screening for side effects, screening for direct adverse effect. For example, if patient is feeling dizzy because of the blood pressure medicine or because of the sedative medicine, that is not the direct harm, it's a side effect that can potentially cause harm. When opposed to that, if NSAIDs are directly affecting kidneys and liver, that, like, direct kidney damage, direct liver damage. So different types of harm. In summary, more harm, less benefits, we should consider deprescribing. Patient are not complying. So patients are not compliant because of size of the tablet, because of the um, taste of the tablet, because of the regimen that he needs to take it or she needs to take it, or patients are just outright non-compliant, no other reason at that time. So if patients are making an informed choice of not using medicine, definitely no point in continuing. We should prescribe. If patients are non-compliant because of an obvious reason, we should try to um, fix it, or we should try to explore what is happening there. Low quality of life. If medicines are supposed to increase the quality of life in that patient, the indication is just to increase quality of life, and they are not uh, increasing the quality of life, they are actually decreasing the quality of life. No reason. So, for example, we use painkiller, for example, gabapentin, pregabalin. We use it for neuropathic pain. If patients, and mainly is to avoid pain and improve the quality of life. If the pain is not adequately managed, despite choosing the appropriate dose, but is giving side effects to them, we either should decrease the dose, do something else, try to use another intervention or another medicine, because it's basically not helping the patient at all. Unnecessary medicines are really causing a great deal of opportunity cost. Why? Because the medicines that we are using in people where there's no use for medicine, we can use it for other people. So it's really important that we consider it is not just about saving money in a particular patient, but rather utilizing money at its best. Now, barriers to prescribe, excuse me, Um, I think that nursing paper that I've shown you has talked about those barriers. Is really important. Um, a lot of barriers are there, but if you think about it, they are either patient related, prescriber related, or system related. So medicine related, they are not the barriers to prescribe. So you may think that some medicines are harder to be prescribed, but I mean, they are harder, like any deprescribing of medicine is harder because it requires careful monitoring, as we'll discuss later. But the barriers to deprescribe, the things that are going to limit the opportunity of deprescribing, patient think that it's really needed. They are used to it. Um, they think it's beneficial to them, so they may have some perceived benefit. We can review it if they are actually arising from medicine or they are not arising from medicines. They might feel that some big doctor have started it, so they don't want to discuss it. They are obliged to that consultant who they feel is way more um, authoritative in that disease than you are. So that's why they may don't even want to discuss it with you. So they are real barriers. The way you overcome with it is having an honest discussion with them, exploring the possibility, and giving them information. Sometimes it's just providing the information that they can reflect on, is the key here. Now, barriers to prescribe related to prescriber. Medicines are very easy intervention. It's a learned behavior. You see a patient, something wrong, you prescribe. Uh, you believe that medicine really are effective. So in indication where there is not even more evidence, you may have your own personal bias. You don't know that those medicine can be prescribed. You don't know the indication of it. It's not just the lack of technical knowledge about medicine, but it may be lack of knowledge related to medicines, the history of medicine, or whether that medicine is being started and what were the indication, what were the circumstances, fear of litigation if they stop something, something happened to the patient, limited knowledge about patient if you're a locum, if you don't know patient very well, it's your first consultation with them, you just don't want to suggest something because patient might think that you are saving money. System related, I suppose, are the really important barriers and really the main reason why we have so much problem in deprescribing is the time or follow-up. Deprescribing, as you'll see in the process paper that I'm going to refer to in the next slide. It's really difficult to deprescribe, especially you need to have established mechanism. You need to make sure that there's excuse me, there's good opportunity to follow up patients. Um, there are less chances of patient falling into the crack and you forgetting about it, and then they experience some adverse effect from deprescribing or withdrawal effects, inefficiencies in the systems. So system don't remind us, we don't realize it. There's no time for review, and then there's incentives to prescribe for, well, pharmacy, and you know the patients get really happy if they get the medicine, um, and there's no incentive to basically discourage prescribing. So there's whole machinery of pharmaceutical industry and commercial pushing of products that towards prescribing, working towards prescribing, but the good Samaritan force of deprescribing is can be easily pushed away because there's no incentive to deprescribe as compared to prescribing. Now, before you deprescribe, there are a few questions, but what do we need to do is, even before that, let's talk about our second reading. So I'm only giving you two readings. So number one reading, I've already told you about nursing literature, 3 pages. This is a review of deprescribing process. Now, this is a really good paper. Now, the reason I think it's a good paper is because it's not just a process, a patient-centered deprescribing process. As you'll see, and I'm going to use that figure here in our talk, and then you can review it in this paper as well. As you'll see in this paper, that the deprescribing process is actually based on evidence. So for each step that they are suggesting is based on this literature review, and for each questions that they are answer is talking about specific evidence. So this is the process. So step one, and let's go back to the slide. So I'll tell you that before you deprescribe, what you need to know and how you deprescribe. Excuse me. But let's see the process of deprescribing that is being developed by expert in the field is need to have comprehensive medication history, identify potentially inappropriate medications, determine if medication can be seized and prioritized, plan and initiate a withdrawal, monitoring, support, and documentation. So these are the important 5 steps. And if you see about these 5 steps, you can see that for each one they are talking about um, 6 of the included articles report this as an element of deprescribing, with only 2 of those citing relevant research as to why this is required. So what they are doing, they have established this process. So they are saying this step one, comprehensive medication history, but they actually went to actual evidence that how it helps. So then you can be assured that if you're following this step, there's a good basic. Now some of them are really obvious thing. For example, taking a comprehensive medication history is like, you know, you don't need an evidence to support this. But the good thing is that if you are providing an evidence, then that process can be easily incorporated into various organizations, because then it makes it easy for people to just use it. Now, identifying potentially inappropriate medication and determine whether medication can be stopped and seized. I'll leave it to you so that you can read and understand. But let's go back to our slides. So, excuse me. I think pre-deprescribing, you need to have some understanding. So pre-deprescribing, you need to first of all realize that is that patient understand what you're trying to do. So think about it. If we are going for a health check, a routine patient appointment with our doctor, and we have just been informed that you look, we are trying to withdraw a medicine of your list, and let's see how you go. You'll be a bit apprehensive, you're a bit, uneasy about it, anxious about it. So it's really important there should be a mutual patient understanding between you and the patient about the potential benefit, and if they are really willing to participate in a trial withdrawal. For your own self, do you think that there are some tests that you would like to do before and after? You need to make sure that you have all the information. You perhaps want to read about it. What are the potential side effects? If patient asks any question, does the patient need any counseling? Especially what information there is about withdrawal effect? Are you expecting some withdrawal effect? What will be the difference between patient feeling unwell generally related to medicine, all of that. Now, and also what follow-up is required. Now, it's easy to say these things without the context, but it's really difficult when we kind of try to contextualize it, and that is where I will be including this short video. Just bear with me because this particular program that I'm using does not allow me to um, use Chrome. So while I'm recording, I cannot use Chrome, but once I have started recording, I'm pretty sure this program won't have any idea that I'm using. Yes, so we are good to go. Yes, so I can't open YouTube because it will probably, cause all these dramas. But now I can do it. So let's see. There's this excellent deep prescribing network that you can use. Uh, but I'll probably just use one video of them, and then that video will explain to you that how it works. So because I'm speaking on this microphone, I'm pretty sure you won't be able to, or maybe you will listen to something because I'm using the headphones, so you won't be able to listen to the video. But this video will be available in your page that you are viewing right now, where you are actually getting this talk. So if you if you go through with this video, it's basically only 9 minutes video, but it's actually going to quite details, as you can see. Excuse me. How you can engage patients, what are the side effects, how do you taper doses, what are on-demand definitions that patient need to be aware of. So all of that information is quite neatly available in this particular video, and you'll see how useful it is. So when I was trying to tell you that you would like to know further details is how you're going to manage all these things in patient, that's how you're going to do. So now um, we know prescribing need a lot of information gathering, processing, and clinical judgment. But when we do the prescribing, you need all of that, what you need for prescribing, plus you have a bit closer monitoring, because you see, when you start something, the effects goes up gradually and patient get used to it. But when you stop something, there's a sudden fall in that medicine that body is used to. So that's why we need greater patient involvement, more motivation from patient side, so that they can overcome some of the irrational concerns, irrational fears, but can watch for as a close monitoring some obvious sign and symptom that they need to watch to make sure that the deprescribing is a safer process. Now, uh, hands-on practice, as you will see the video, the review of algorithms, an example of PPI. So I'll upload this video for you. That will be your first hands-on kind of practice, um, um, not really hands-on practice, but kind of observing. So, as your prescribing portfolio contact sheets, so you observe, being observed, and then independent. So this will be like, you're observing others, getting deprescribing. Uh, Toolkit, as you can read through toolkit and see how you'll do deprescribing, that like kind of being observed. Most of you will say, nah, that doesn't make sense. But finally, the review of a prescribing contact sheet, that we are going to use an example, and how you're going to then apply it kind of independently, doing deprescribing, and then you can learn directly from it. So thank you very much for bearing with me. Before we stop this talk, let me show you the other two things that I was talking about. So as you can see, this is the deprescribing resource pack. So this is one of the NHS Trust. This resource pack is very good. It defined what the polypharmacy is. It's also talk about what are the different definition of polypharmacy, what is deprescribing, 5 steps. They've chosen their 5 steps of deprescribing. I've given you, so there are different approaches to it. You can pick and choose which one you would like. It talks about the most common medicines that are employed in deprescribing, so that's really important. NSAID, diuretics, blood pressure tablets, CNS tablet, antipsychotic, antihistamine. So these are the most common medicine cause side effects, adverse effect, and then we like to review the use of these. And then if you keep going, then tools for medication review. So you can actually look into some of these tools. There's start stop criteria, no tears tool, acronyms. MedStopper tool is an online tool. So basically you can just go online to medstopper.com, and then you can um, type in all the medicine, and it will going to tell you that which one should be deprescribed and how to deprescribe it. So very useful resource. Please read it. Read it while you're trying to do deprescribing. Excellent use of the resource as well. And that should be really good for you. Um, and the last one that we have, a prescribing contact sheet that I'll upload. I think it's in my other folder. So I'll upload a prescribing contact sheet where you can just, we'll just go through the example of deprescribing. So um, I'll actually show you. Let me pause this. So so I've just paused the video to find out the contact sheet that I'll upload for you guys for this activity, and I just want to go through with it so that you understand that how you can apply in your own practice. So this is basically 67-year-old male admitted with multiple episode of collapse, no proceeding symptoms, injured right shoulder during the collapse. So obviously some patient harm is being observed. No chest pain, shortness of breath, no seizures, head injury or speech or vision disturbances. Obviously some reduced appetite and weight loss. Um, Type 2 diabetes, hypertension, and folate deficiencies. Patient is on atorvastatin, folic acid, linagliptin, DPPI-4, paracetamol, codeine, metformin, ramipril, some morphine, quite a lot of painkillers. So basically some senna, obviously, to overcome excuse me, to overcome The constipation related to opioids, blood pressure not too bad, heart rate, respiratory rate, so no temperature. You can have blood, so creatinine seems to be okay, sodium potassium normal, HB baseline, some MCV is low, LFT normal, mid-zone lesion, lung cancer, shoulder X-ray, right clavicle fracture, look uncomfortable, in pain on paracetamol, codeine, and morphine, chest clear. So new diagnosis is lung cancer, review pain control. So obviously something is going on which is more than what's just his past medical history. Now, when you're looking at the medication and you see fall, this patient may have some sort of cancer been recently diagnosed, so maybe on painkiller, he may be receiving some additional treatment. I'm not sure uh, what else is available here. So, treatment options, consider what you could do at this stage. Okay, so optimize pain relief. Okay, as per WHO pain ladder, review opioid choice and renal function. So yep, that's fine. So renal function, some of them can accumulate, some of them accumulate less, um, and that's it. So this is obviously a patient contact sheet which is very specific to pain. Um, I would actually recommend you, if you are looking at from deep prescribing point of view, just go beyond one aspect, which is excuse me, obviously patient having a fall because of the dizziness, um, pain is still not controlled, so obviously patient is having a weak opioid which is codeine, but then having a much stronger opioid as a PRN. This patient is on reasonable number of medicines, so at least polypharmacy 1, 2, 3, 4, 5, 6 regular, and pain management so 7, 8, and then PRN for constipation. God knows what else for other cancer treatment if there is one. So obviously this patient is high risk of problem with polypharmacy. Um, you also need to ask yourself that what the cholesterol level is, when the atorvastatin was started, if it is for secondary prevention or primary prevention presence of diabetes, dose seems to be pretty low. Folic acid deficiency, when it was diagnosed, folic acid deficiency is often caused by receptor problems. So if it is that kind of deficiency, then you probably need to ask yourself that why oral, why not, you know, in course of injection and then every 3 months, and um, replacement of folic acid via injectable route is the most common treatment. Oral is very unlikely to be absorbed if that's the problem. Linagliptin is perhaps quite a starting dose with metformin 500 milligram BD. You can actually combine them. There are combination available for linagliptin and metformin that can also decrease the pill burden in patient like this. You need to ask yourself, was the fall related to dizziness or was the fall related to orthostatic hypotension? The blood pressure seems to be normal, so obviously that's not the case. Um, and then when you are applying the principles, as you see in this case, this is all about applying and rationalizing the morphine and pain treatment, but you need to think harder about all the other medicine that this patient is taking and whether there is a rationale for those medicine or not. So this is how you can apply. You look at the medicine and go through with all of that. It's not a very common example. It's not a very easy example of deprescribing. So I'm not looking at things that are so wrong that you don't even need to think about it. I've chosen this one, which is like a normal, everyday kind of um, prescription in front of you, a patient in front of you with a set of medicine that may or may not be inappropriate. And that's a very good kind of exercise for applying deprescribing, because it won't have a very obvious reason other than polypharmacy. So this example will be available. I just need to take out the last page of it before I upload it so that it's not identifiable. Um, and that will do. So once you have done this example and you are more comfortable, then I'll suggest that um, explore how you're going to implement deep prescribing in your own practice setting. And I think after going through with all these resources and after going through with all of this, you should be able to demonstrate the competency required to practice deep prescribing in your practice. Thank you very much for listening to my talk, and thank you also in anticipation that you're going to read the material well. And if you have any questions, feel free to email me or contact me. Uh, my email will be available. I'll include it in the last section, or it should be available in the module handbook anyway. So if you have any question, feel free to email me or send me questions, and I'll be more than happy to answer those questions. Okay, thank you very much.